Good morning, everyone. So, how are you? Hope you are all preparing well for your NEET-PG exam. You have only a couple of days left for the exam. So, today's session is IHEAL session on pediatric. So, today for the next 1 hour, we'll be discussing on some previous year questions and previous year topics, which is very, very, very high need. Okay. So, shall we start with the session? Okay. The first question: what is normal in an infant with 2.8 kg birth weight? Okay, so birth weight is 2.8 kg. What is normal? Weight gain of 300 grams till 3 months. Is it correct? Increase in length of 25 centimeter in a year. Anterior frontal closes by 6 months. Weight under 75th percentile and height under 25th percentile. So which is normal? Weight gain of 300 gram in 3 months. No, you all know that per day the baby gains around 20 to 30 grams. So even if you take for 1 month, it is going to be around 900 grams. Okay. So that is not a right statement. Yes, increase in length of 25 centimeters in a year. Yes, it is true. Anterior fontanelle closes by 9 months to 18 months. Okay, so anterior fontanelle closes by 9 months to 18 months. It is not 6 months. Weight under 75th percentile and height under 25th. Weight is fine, but height under 25th is also going to be on the lower side. So both are wrong statement. So here the correct answer is option 2. Okay, so some few important points about growth. So we are going to see some important parameters. The first one, this is called as an infantometer, which is used to measure length in a child who is less than 2 years. And for height in a child who is more than 2 years, you will use stadiometer. At birth, the length is 50 centimeters. 1 year, 75 centimeters. 25 centimeters it increases. 2 years, 87.5 centimeters. Height doubles by 4 years, and half of adult height is reached by 2 years. Okay, coming to weight. So this is a weighing scale which is used to weigh infant. At birth, the normal weight is around 2.5 to 3.99 kg. The average birth weight, okay, if someone asks you the mean birth weight or average birth weight, is going to be 2.9 kg. Okay, birth weight doubles by 5 months, triples by 1 year, quadruples by 2 years. Fine. Okay. The next very important image-based question, what is this? This is a Shakey's tape. So Shakey's tape is used to measure the mid-upper arm circumference. So what is the use of this tape? It is used to assess malnutrition. One, next it can be used by frontline workers. Okay. So according to the colors, we have 3 different categories. If it is in the red zone, it is less than 11.5 centimeter. It is severe malnutrition. Moderate is yellow zone, 11.5 to 12.5 centimeters. Normal is green zone, that is more than 12.5 centimeters. Fine. So these 3 are important growth parameters which you should know before going to the exam. Okay. So interpretation of growth, this is also very important. They can give you a scenario or a growth chart and they can ask you what is this. When height for age is below -2 standard deviation, you use the word stunting or short stature. Okay. When height is reduced, it is stunting or short stature. When weight for age is reduced, it is called as underweight. When weight for height is reduced, it is called as wasting. Okay, fine. In case of wasting, it is acute malnutrition. In case of stunting, it is chronic malnutrition. Okay, weight for age, you cannot say whether it is acute or chronic. Both in acute and chronic, it is affected. Fine. Okay, so when height is affected, it is chronic malnutrition. Fine. Going to the second question. Bidextrous grasp is seen at what age? Yes, what is the answer? Direct question. Yes, you can comment your answers in the chat box. Bidextrous grasp is seen at what age? Very good. It is 4 months. Yes, very good. 4 months. So some fine motor milestones which we have to remember. Bidextrous reach 4 months. Unidextrous 6 months. Immature pincer grasp is 9 months. Mature pincer grasp is 1 year. And coming to some scribbling and drawing. So 18 months the baby scribbles, 2 years vertical stroke, 3 years circle, 4 years cross, 4.5 years rectangle, 5 years triangle. Okay. Similarly, 8 months, 3 blocks, 2 years, 6 blocks, 3 years, 9 blocks, 4 years, the baby will be able to make a bridge, 5 years gait. Okay. These are some important fine motor milestones that you should know. Third question, very, very important questions, multiple time repeat. An infant presents with hepatosplenomegaly, thrombocytopenia, periventricular calcification. What is the diagnosis? Yes, very good. Whenever you see the word periventricular calcification, you go for congenital CMV. Okay. So two important congenital infections that can present with calcifications. What are they? The first one, you see the calcifications around the ventricle. In the second one, you see the calcifications which is diffuse. Okay. The first one is CMV, very good. The second one is toxoplasmosis. Periventricular CMV. Okay, diffuse calcification, it is toxoplasmosis. Good. Some congenital infections we will discuss. Okay, triad of sensory neural hearing loss, cataract, and cardiac defects. Most commonly, patent ductus arteriosus is seen in congenital rubella syndrome. Okay, triad of hydrocephalus, macrocephaly, chorioretinitis, diffuse intracranial calcification is seen in congenital toxoplasmosis. The drug of choice in pregnancy is going to be spiramycin. Okay, spiramycin. Okay. When a child presents with microcephaly, periventricular calcifications, jaundice, hepatosplenomegaly, you're going to think about congenital CMV infection. The most common long-term complication of congenital CMV is sensory neural hearing loss. Treatment is ganciclovir. What is the investigation of choice you will do? Specimen? Yes, it is urine CMV PCR. Urine specimen is used. Okay. Next, severe microcephaly, vector-borne disease, you will think of congenital Zika virus. Okay. Yes. Yes. Urine CMV within 2 weeks. Okay. 2 to 3 weeks, not after 3 weeks. Next, when you see the word eye drops fetalis, it is non-immune eye drops fetalis, then you're going to think about parvovirus B19 infection. Okay. So coming to Hutchinson triad, interstitial keratitis, deafness, and notched, central notched incisors. You will think of congenital syphilis, which is late syphilis. Earliest sign of congenital syphilis is snuffles. That is the purulent nasal discharge. Okay. Last congenital infection, cicatrizing skin lesions with limb hypoplasia. Scarring skin lesions with limb hypoplasia, you will think of congenital varicella infection. Okay. So very important congenital infection. One question can definitely come from that. Okay. Fine. Moving on to the next question. Apgar score at 3 minutes. At 1 minute indicates. At 1 minute, if it is 3, it indicates what is the answer? Yes, it is severely depressed. Very good. Severely depressed. So we will see about Apgar. Everyone knows what is Apgar. Appearance, pulse rate, grimace, activity, respiratory effort, not respiratory rate. Okay. Completely blue 0. Extremities are blue 1. Completely pink 2. Pulse rate, absent 0, less than 101, more than 102. Grimace, no response. Grimace and coughs. Okay. Activity, no activity, some activity, and active activity. Respiratory effort, not rate. Absent, weak respiratory effort, strong cry. Okay. So if your Apgar score, you're going to see at 1 minute and 5 minutes, and you can extend up to 20 minutes if it is less. Okay. So if it is less than 3, it means the baby is severely depressed. Okay. 4 to 7, it means the baby is moderately depressed. More than 7 is normal. Okay. So Apgar is used to see the outcome of the baby. Apgar cannot be used as a guide for resuscitation. Okay. Other important scores that can be used in newborn. Downey score. It is used for respiratory distress. Okay. The components of Downey score, the mnemonic is Kargar. What is Kargar? Cyanosis, air entry, respiratory rate, grunt, retraction. Kargar. Okay. Silverman-Anderson score, upper chest movement, lower chest retraction, xiphoid retraction, grunt, and nasal flaring. Even in Silverman-Anderson score, no respiratory rate. Okay. This is also used for respiratory distress. Next, Sarnath and Sarnath score. Just remember, in Sarnath and Sarnath, stage 2 will have seizures. This score is used for HIE, hypoxic ischemic encephalopathy. Next, bind score. What is bind score? Bilirubin-induced neurological dysfunction. That is the bind score, which is used in neonatal jaundice. Okay, it is used in neonatal jaundice. The mnemonic is MMC, mental status, muscle tone, and cry. These are some scores which is used in newborn. Okay, fine. Okay, going on to the next question. Another repeat question. Severe acute malnutrition as per WHO. What is the answer? Yes, weight for age below -3 standard deviation. Yes, weight for age below -3 standard deviation is the answer. Very important criteria for SAM, 3 criteria. Weight for height. Okay, not age, weight for height. So weight for height below -3 standard deviation. Mid upper arm circumference less than 11.5 centimeter. This cannot be used in a child less than 6 months. bilateral pedal edema. These are the criteria for severe acute malnutrition. Please remember, it is wait for height. Okay, next question. 10 months old female infant presents with jerky movements of lips towards the body. EEG shows its arrhythmia. The baby also has delay in attaining developmental milestones. Drug of choice. Very good. ACTH. What is this condition? This condition is? Yes, West syndrome. Very good. West syndrome, also known as infantile spasm. West syndrome is characterized by a triad of, yes, infantile spasm, that is the jerky movements, and retardation, mental retardation or psychomotor retardation, and EEG showing a characteristic finding called as hypsarrhythmia, okay, which is be chaotic EEG. The EEG will be chaotic like this. That is hypsarrhythmia. Drug of choice is always ACTH. The second line oral drug which you can use is steroids. ACTH is injectable. Okay. Tuberous sclerosis with West syndrome, the drug of choice is vigabatrin. Very good. Vigabatrin. Fine. Okay. 2-month-old infant of an HIV positive mother presents with diarrhea. What is the next best step in management? There is a mother who is HIV positive. There is a baby born to that mother and the baby is having diarrhea. What will you do first? Yes, first you have to rule out HIV. You have to screen HIV. So it is dried blood spot for HIV PCR. Okay, dried blood spot for HIV PCR. So some important terminologies have changed regarding HIV in newborn. So that we will discuss. Test for HIV exposed infant. What is the test we are going to do? HIV PCR. What PCR? Is what PCR? Total nucleic acid. Very good. TNA PCR, which is a dried blood spot. DBS, dried blood spot. Timing of the test. Initial test, when will you do? 6 weeks. Then 6 months. Then 1 year after stopping breastfeeding. And definitive test, when are you going to do? At 18 months. 18 months. What test you are going to do? Definitive test. Antibody test. Okay. Before 18 months, you don't do antibody test. Only at 18 months, you do the antibody test. Yes. Breastfeeding. Can I breastfeed or not in HIV? Yes. Breastfeeding is not contraindicated. Prophylaxis. Are you going to give prophylaxis? Yes. For all babies. Low risk babies, the prophylaxis that is used is nevirapine, which is used for 6 weeks. High risk babies, you will give 2 drugs, dual prophylaxis. What are they? Nevirapine plus zidovudine. Nevirapine plus zidovudine. The duration is 6 weeks in case of breastfeeding, 12 weeks in case of, 6 weeks in case of formula fed infant, 12 weeks in case of breastfeeding. Okay, fine. So high risk, low risk. In the class, I have detailedly told what is high risk and low risk. Okay, pro-time prophylaxis for all babies. You start at 6 weeks. Continue till HIV is excluded. Okay, continue till HIV is excluded. Why you give cotrimoxazole? To prevent pneumocystis cerevisiae infection. Okay, this is about the guidelines of HIV exposed infant. Okay. Next question. 11-month-old baby presented with incessant cry on examination. There is a tender mass per abdomen in the right lumbar region. Varia minima is shown. What is the diagnosis? Even without the options, you should tell me the diagnosis. Very good. So with the history itself, you know that incessant cry and lumbar region, there is a mass. And varia minima shows 2 signs. What are the 2 signs? Claw sign and coiled spring appearance. The answer is intersusception. Okay. Okay, so these are the important points to point towards intersusception. Abdominal pain. So infants with abdominal pain, they will present with incessant cry. So look for incessant cry, recurrent jelly stool, abdominal distension, a mass like this, which has a concavity towards the umbilicus. Right iliac fossa will be empty. That is called as dance sign. And in the varia minima, you will see claw sign and coiled spring appearance. And USG, you will see a sign called as target sign. Okay, in the USC, you will see a sign called as target sign. Okay, fine. Treatment, hydrostatic reduction and surgery. Okay, fine. Which vaccine predisposes to interception? Rotavirus. Good. So that is why after 1 year, you're not going to give rotavirus. Only till 1 year, you can give rotavirus. Next question. Yes. 10 years old male child, bloating of abdomen, steatorrhea, reduced height and weight. So there is malabsorption, failure to thrive, HLA-DQ2 positive. What is the diagnosis? Everyone knows, yes, gluten insensitivity, celiac disease. So here you're going to give gluten-free diet. Okay, so what are the clues? Chronic diarrhea, failure to thrive. If you see, think of celiac disease in children. So what is celiac disease? Intolerance to bro substances. Who are the bro? Barley, rye, oats and wheat. Okay, barley, rye, oats and wheat. Rice and maize are safe. What is the investigation of choice? Biopsy. Intestinal biopsy will show villus atrophy. Okay, other investigations you will do anti-NEETPG, transglutaminase, okay, tissue transglutaminase A, anti-endomysial antibody, and recent recommendation is that you will do IgA levels as well. IgA levels as well. Okay, so for this, you have a grading system called as Marsh grading system. The treatment is you just avoid bro, the child will be happy. Okay, fine. Good. Next. A 10-year-old child presents with edema, anasarca, masoproteinuria. Diagnosis of minimal change disease was done. Which among the following statement is true? Light microscopy shows effacement of photocyte. True or false? False, because electron microscopy is going to show this effacement. Very good. Good response to steroid. True? Yes. Most common in adults? False. Yes, it is common in children. Non-selective proteinuria? No, it is highly selective proteinuria. Okay, so all these three are false. The correct answer is good response to steroid. Okay, fine. Two important renal diseases you have to know. One is PIGN, the next one is nephrotic syndrome. So what is PIGN? Post-infectious glomerulonephritis. Most common cause here is going to be group A beta hemolytic streptococci. So here the presentation will be edema, oliguria, hematuria, cola-colored urine, hypertension. Look for these two things, cola-colored urine, hypertension. If that is there, go for PIGN. Okay. Two important findings. Electron microscopy will show subepithelial humps. Immunofluorescence will show IgG-C3 glandular deposit. One characteristic finding in PIGN, serum complement C3 levels will be reduced, and it is a self-limiting disease. Okay. The duration between sore throat and these symptoms will be sore throat and the symptoms in PIGN. How much will be the duration? The child presenting with sore throat. After how long the child will present with symptoms? Yes, 1 to 2 weeks. Okay, not less than 1 week. Okay, suppose the same scenario, they say the child presents with upper respiratory infection within 1 or 2 days of infection, the child presents with hematuria. What will you think? IgA nephropathy. Very good. IgA nephropathy. What is the characteristic feature you will see? Immunofluorescence. What is the characteristic feature you will see? Where will be the deposits? Whenever there is IgA, think of mesangial. Very good. Okay, fine. So, coming to our question, massive proteinuria. Massive. When will you say massive? More than 40 milligram per meter square per hour. Then you will call it as massive. Okay. So, or 3 plus 4 plus proteinuria is massive. Edema is there. Cholesterol is increased. Hypoalbuminemia. No hematuria, no hypertension. Key points. No hematuria, no hypertension. Think of minimal change nephrotic syndrome in children. Most common in children. Electron microscopy will show effacement of food process, and the drug of choice is steroids. How long you will give steroids? 6 weeks first. 2 milligram per kg per day. Followed by another 6 weeks of 1.5 milligram per kg per day. Okay, total 12 weeks duration. Okay, fine. 8-year-old male child presents with palpable purpura over lower limbs, as shown in the image. Okay, complaint of arthralgia and abdominal pain. There was a preceding history of upper respiratory infection. Which of the following drugs is used? Now tell me, what is the diagnosis first? Palpable purpura. What will you think? HSP. Good. Enoxaparin purpura, very, very good. So enoxaparin purpura or IgA vasculitis. These are the other terms. Okay. So where you will have the rashes, typically over the lower extremities and the dependent parts, the buttock region, lower extremities, Arthralgia, abdominal pain will be there. Treatment, usually you don't treat for minor symptoms. But if there are going to be severe symptoms like abdominal pain and all, you will give steroids. Okay. So that was the ionized question, right? HSP, when will you treat? When severe GI symptoms are there. Okay. So this is HSP. IgA vasculitis. Okay. Another important question, child presents with infantile hypertrophic pyloric stenosis, multiple episodes of non-bilious vomiting. What does it cause? Characteristic question. Yes, even in sleep, if I ask you, you are going to tell me. What is it? It's hypokalemic, hypochloremic, metabolic alkalosis with yes, hypokalemic, hypochloremic, metabolic alkalosis with complete, very good, paradoxical aciduria. Okay. So IHPS, what are the clues you're going to look at the question? Ideally around 3 weeks. Okay, not in the newborn period. 3 weeks. Male child who presents with persistent incessant cry, vomiting, which is characteristically non-bilious, okay? And on examination, you see an olive-shaped mass in the epigastrium with visible gastric peristalsis and electrolyte imbalance. What is that electrolyte imbalance? Hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria is going to be there. Your diagnosis is going to be IHPS, which is idiopathic hypertrophic pyloric stenosis, okay? Investigation of choice, ultrasound. Treatment, what is the named procedure? Ramsted's pyloromyotomy. The named procedure is Ramsted's pyloromyotomy. Okay, fine. Suppose they say a newborn with bilious vomiting, no abdominal distension, and X-ray shows double bubble appearance. Your diagnosis is going to be duodenal atresia. Okay, characteristic features. Period is newborn period within 24 hours. Bilious vomiting will be there. No distension. Think of duodenal atresia. Okay. Which syndrome is most commonly associated with duodenal atresia? Is Down syndrome. Duodenal atresia is very, very common. Any other GI congenital anomaly which is common in duodenal atresia? In Down syndrome? Hirschsprung. Okay. Hirschsprung is also common in Down syndrome. Okay. Fine. So another important topic, national immunization schedule. I expect at least one question from that schedule in NEET-PG, definitely. Okay. So coming to this, again and again, I'm telling you, please memorize this schedule before you go to exam. This is something which has to be in your last minute notebook. Okay. At birth, BCG, OPV, hepatitis B. 6 weeks, 14 weeks, same. Pentavalent, PCV, FIPV, OPV, and Rota. Okay. 10 weeks, pentavalent, OPV, Rota. You don't give PCV and FIPV. Okay, 9 completed months or at the 10th month, FIPV third dose, PCV booster, JE first dose, MR first dose along with vitamin E. Okay, 1.5 years you give JE second dose, MR second dose, a DPT booster, OPV booster. 5 years, a DPT booster, 10 and 16 years, TD booster. Okay, now coming to HPV vaccine, still under question. So it is being incorporated into national immunization schedule. Right now, only in certain districts it is being done, not in all districts. Okay, so HPV vaccine, few important points we will see because there's high probability of asking HPV vaccine. So the protein that is used in HPV vaccine is L1 protein. So 3 vaccines are there. Cervavac, which is India's vaccine, Cervarix, and Gardasil. Okay, 3 vaccines are there. Okay, Cervavac is quadrivalent. Cervarix is only double valent, that is bivalent. Gardasil, you have quadrivalent and 9-valent. Okay, so coming here, L1 protein is used. The oncogenic strains, 6, 11, 16, 18. These are the 4 strains. Among these 2 are oncogenic. 16 and 18 are oncogenic. 6 and 11 are non-oncogenic. So who is approved of getting HPV vaccine? Adolescent girls. In India, only adolescent girls. Okay, so if the age group is 19 to 14 years, you will give 2 doses. If the age group is more than or equal to 15 years, you will give 3 doses. Okay, 3 doses. So this is going to be the schedule for HPV vaccine if it comes. Okay, 2 image-based questions which is asked multiple times. Okay, so like I'll take up all the doubts at the end. So save your doubts. Even if something is there, we'll do that. Okay, a 3-year-old child presents with fever, barking cough, stridor. Okay, fever, distress, barking cough with this X-ray. What is this? First one, what is the sign? Steeple sign. Where will you see steeple sign? ALTB, good. Acute laryngotracheobronchitis or croup, that is the answer. Even without X-ray, you should be able to say with the scenario, barking cough, and fever, mild distress. That will be the scenario in case of ALTB. ALTB, no need antibiotics. Okay, most commonly caused by para-influenza, so you don't need antibiotics. So what you will give? You will give oxygen. That is very important. Adrenaline nebulization and steroids. That's all. That is what you give for ALTB. For acute epiglottitis, so 3-year-old, you will look for these toxic child presence with distress. Suddenly, the child presents with distress, high grade fever, and drooling of saliva within 4 hours of fever. And X-ray, if you say, you will see the thumb sign. Okay. What is the diagnosis? Yes, acute epiglottitis is going to be the diagnosis here. So in acute epiglottitis, the child will be very sick compared to ALTB, where the child is somewhat better. So among these two, which is an emergency, acute epiglottitis is an emergency. Here in acute epiglottitis, your mainstay of treatment is securing your airway. So elective intubation under sedation is first option. If that is not possible, go for tracheostomy. Okay, and you need IV antibiotics here. Why? Because it is caused by H influenza. ALTB is viral, para-influenza, whereas acute epiglottitis is caused by H influenza. So you give IV antibiotics, preferably IV ceftriaxone, third generation cephalosporin. Okay, these are the cross differences. Okay, another important topic, which is very, very important, is pneumonia. Okay, so pneumonia, they will give you scenario and they will ask you the grading of pneumonia. 3 gradings are there: no pneumonia, pneumonia, severe pneumonia. When will you say no pneumonia? There is only cough and cold, respiratory rate is normal. Okay, respiratory rate is normal, then it is no pneumonia. No pneumonia, you send the child home. No need of antibiotics, only supportive management. Give paracetamol for fever and antihistaminics if that is necessary. No antibiotics. Pneumonia, when will you call it as pneumonia? Fast breathing plus or minus chest indrawing. Plus or minus. Okay. Plus or minus chest indrawing. What is fast breathing? Come to the respiratory rate. Okay. In a child who is less than 2 months, more than or equal to 60 per minute is tachypnea. 2 months to 1 year, more than or equal to 50 per minute. 1 to 5 years, more than or equal to 40 per minute. 60, 50, 40. If it is more, then it is tachypnea. So if it is there plus or minus minimal chest indrawing, it comes under pneumonia. So pneumonia, here also you will send the baby home, but with oral antibiotics. What oral antibiotics you are going to give for 5 days? That was the previous year NEET-PG question. What oral antibiotics you will give according to IMNCI? Amoxicillin, yes. Amoxicillin you will give for 5 days and send them home. Okay. The third category is severe pneumonia, very severe, come together. So you look for danger signs. What are the danger signs? Not able to drink, persistent vomiting, convulsions, coma, lethargy, stridor in a calm child, and severe malnutrition, and one more, severe retraction, severe indrawing. Okay. So severe indrawing will all come under severe pneumonia. In severe pneumonia, you're going to hospitalize the child or refer the child. And you're going to give IV antibiotics. What IV antibiotics you will prefer here? Yes, Ampi and Genta. Ampicillin plus gentamicin is preferred here. Okay. So if they give you scenario, this is how you classify and come to the diagnosis. Okay, fine. Very, very important topic. Okay, next important topic is about the UTI. Okay, urinary tract infection. So the sample can be collected by clean catch, catheter, or suprapubic aspiration. Okay, in clean catch, if it is more than 10 power 5 colony forming units, it is positive. In catheter, if it is more than 10 power 4 colony forming units, it is positive. Suprapubic aspiration, recent guidelines says more than or equal to 10 power 3. Previously, it was any organism, but recent guidelines say suprapubic aspiration more than or equal to 10 power 3, you take it as positive. Okay. This is the screening for UTI. Any child who presents with you with UTI, the first investigation you're going to do is ultrasound. Ultrasound is normal. Don't worry. Ultrasound is abnormal. Go to the next investigation. Micturating cystourethropy. MCU is normal. Don't worry. MCU is abnormal. If it shows vesicoureteric reflex, do next scan, that is DMSA. 3 investigations you're going to do: USG, MCU, DMSA. Fine. Okay. So even if ultrasound is normal, 2 criteria for you to do MCU. What is that? Recurrent UTI or organism other than E. coli in a child who is less than 2 years. Even if USG is normal, you will go to MCU. Clear? Okay. Next, very important topic. So nowadays, at least one question comes from this topic. Even in INSET, you had one question. So what is this? This is Kawasaki disease. So Kawasaki disease, what vessel vasculitis? Medium vessel vasculitis, Kawasaki disease. Important points. It is also known as acute mucocutaneous lymph node syndrome. It is the most common vasculitis in children in Asia. In India, it is most common. Overall world, it is HSP. But in India and Asia, this is becoming very common. Okay, most common acquired heart disease. It has replaced rheumatic heart disease. In the books also, they have said that Kawasaki is most common. Okay, mnemonic crash burns. So burns is fever. Definitely burns has to be there. I mean, fever has to be there for more than 5 days. Crash. What is crash? Very important. Every word I'm going to say is very important. Conjunctivitis. What conjunctivitis? Non-purulent. Non-purulent bilateral. Rashes. Okay. Cervical adenopathy. Unilateral. At least more than 1.5 centimeters. Strawberry tongue. Hand and foot edema and erythema. Okay. Other than this, you will have periungual deformation and all. Okay. Drug of choice is going to be IVIG. Along with IVIG, you will give aspirin for anti-inflammatory purpose also. Okay. So, but if both are given in the option, go for IVIG first. Okay. Complication, long-term complication is coronary artery aneurysm, which we are worried about. Immediate complication, what can happen immediately? Immediate complication, what can you expect? In the first week, what can you expect? Myocarditis, good. Myocarditis is immediate complication. Long-term complication is coronary artery aneurysm. Okay, this is about Kawasaki. They can give you image and ask you. Okay, so look for this. Conjunctivitis, non-purulent, strawberry tongue, edema and erythema, rashes. Okay, this is about Kawasaki. Fine. Okay, another important topic, cystic fibrosis. So what is cystic fibrosis? Autosomal recessive inheritance. CFTR gene mutation, chloride channel mutation. What is the most common mutation? Phenylalanine deletion 508. Okay, deletion 508. Two important systems are affected. One is your respiratory system. Next one is your intestine. What happens in respiratory system? Recurrent respiratory infection. What happens in intestine? Malabsorption. Why all this happens? Why all this happens? Because of defective chloride transport. So one important key point which you have to remember is chloride is decreased in all secretions. All secretions, chloride is decreased except take pancreatic secretion, chloride is decreased. Okay, except sweat gland, because in sweat chloride is increased. Okay, clear? Okay. So investigation, sweat chloride test on 2 occasions, it should be more than or equal to 60 milliequivalents per liter. CFTR mutation is confirmatory. Screening test, sweat chloride test is the screening test. In newborn, the screening test is immunoreactive trypsinogen. Okay, in newborn, immunoreactive trypsinogen. What are the drugs which you can use? The cafters, ivacaftor, lumacaftor, tezacaftor. These cafters are CFTR modulators. And in cystic fibrosis, you can use something called as nebulized antibiotics. What are the antibiotics that can be used? Tobramycin and aztreonam. Tobramycin and aztreonam can be used. Okay, fine. Next. Few nutritional deficiencies we will see. Okay, vitamin A, WHO classification, they can give you image and ask you what is the classification. X1A conjunctival cirrhosis, X1B is bite spot. This is bite spot. X1B. X2 is corneal cirrhosis. X3, A and B you have. Corneal ulcer less than 1/3 of cornea. Corneal ulcer more than 1/3 of cornea is X3B. Xn, night blindness. NFS. Okay, night blindness, fundal changes, corneal scarring. Clear? Earliest symptom is delayed dark adaptation. Earliest sign is conjunctival cirrhosis. Okay, fine. Treatment of vitamin A deficiency. 3 doses you are going to give for treatment. That is 0, 1 and 14. 0, 1, 14. Dose less than 6 months, 15,000. 6 months to 1 year, 1 lakh. More than 1 year, 2 lakh. Okay, 50,000, 1 lakh, 2 lakh. Prophylaxis, only 1 dose you will give. Whereas for treatment, 3 doses you will give. Okay, fine. Next. Another important image or question that is from niacin. Please remember, look for niacin. If not, that is not there, look for B3. Anything can be given. So niacin deficiency, B3 deficiency, it results in pellagra. What are the 4 Ds of pellagra? Yes, diarrhea, dermatitis, dementia, and death. So where will you see pellagra? When a population is on predominant maize-based diet, you will see pellagra. So what is this called as Casal's necklace, which is the hyperpigmentation you see in niacin. Okay. Next, another repeat question. They give you raw egg consumption. When there is raw egg consumption, there is a component called as avidin, which inhibits the absorption of biotin. So you will have biotin deficiency. Biotin is B7. It will present with two important things. Yes, alopecia and dermatitis. Remember, so nowadays your health products, your hair products, and all they say it has a lot of biotin. You take biotin, hair growth will be good, right? So alopecia, dermatitis, think of biotin. Okay. Next, rickets, very important topic. So last year, very important, very simple question they gave. They gave you this image. They asked you what vitamin is deficient. So this is bowing of lips seen in vitamin D deficiency rickets. So rickets has so many causes. Most common is nutritional vitamin D deficiency. Earliest sign is craniotabes. Other signs we all know: delayed closure of anterior fontanelle, delayed dentition, arisons sulcus, rachitic rosary, chest deformity like pectus excavatum and carinum, knee deformities like Varum and Vagum. Okay, fine. X-ray features, what are they? Cupping, fraying, splaying. What is the earliest X-ray feature? Earliest X-ray feature? Yes, in rickets, earliest X-ray feature. Loss of provisional zone of calcification. Okay, loss of provisional zone of calcification is going to be your earliest X-ray feature. So if you see calcium can be reduced or normal, yes, parathormone will be increased, alkaline phosphatase will be increased, 125 dihydroxy vitamin D, that is the active form, will be reduced. That is normal. Treatment, yes, less than 1 year you are going to give daily 2000 international units, more than 1 year 3000 for 12 weeks you will do. So after treatment, if it is not responding to treatment, you call it as refractory rickets. 5 important causes are there. Okay, we'll see one by one. Renal tubular acidosis. When will you say renal tubular acidosis? So first thing you're going to see the pH. When the pH is showing acidosis, it is RTA. Okay. Second cause is CKD. When will you say CKD? When the phosphate is increased, you will say CKD. Okay. So acidosis, think of RTA. Phosphate is increased, think of CKD. Okay. Next, VDDR. When will you think of VDDR? Vitamin D dependent rickets. When everything is similar to rickets. Okay. PTH is increased, calcium is normal or reduced. This is all similar to rickets, but not responding to vitamin D. Then it is vitamin D dependent rickets. Okay. So two types are there, type 1 and type 2. Type 1 is due to the 1-alpha hydroxylase deficiency. Type 2 is due to end organ resistance. So one test you will do, that is the 125 hydroxy D3 levels you will see. If the levels are decreased, it is type 1. If the levels are increased, it is type 2. Okay. Type 1 associated with delayed dentition. Type 2 associated with alopecia and ectodermal defects. Okay. Fine. Last important topic is hypophosphatemic rickets. Hypophosphatemic rickets, here everything will be normal. PTH, calcium normal, but the phosphate level will be reduced. Okay. So think of X-linked hypophosphatemic rickets. It is a X-linked dominant disorder. So here it is because of FEX gene mutation. Okay, FEX gene mutation characteristically presents with lower limb deformities. Okay, these are all the causes of refractory rickets. Multiple times we have discussed this flow chart. So 5 causes. If they give you scenario, put this flow chart and go for the right answer. X-linked dominant. Yes, tell me. X-linked dominant. Other diseases other than rickets, other than X-linked hypophosphatemic rickets, can you think of any other X-linked dominant diseases? Rett syndrome, very good. Rett syndrome, yes. Yes, incontinentia pigmenti. Yes, Alport, it has multiple inheritance. Okay, autosomal recessive, X-linked recessive is possible. X-linked dominant is also possible. Okay, but remember, Alport has multiple inheritance. Anything else? Anything else? No one has told one important disease where they present with intellectual disability, which is the most common inherited cause of intellectual disability, where they will have large face, large jaw, macroorchidism, triplet Very good. Yes, Fragile X is also X-linked dominant. Okay. These are all some important common things which you should know. Okay. So Fragile X, what is the repeats? What repeats you will see in Fragile X? Very good. CGG repeats. Any other triplet repeats can you think of? CTG repeats, where will you see? Very good. Myotonic dystrophy. What cataract you will see in myotonic dystrophy? Christmas tree cataract. Very good. What is the inheritance of myotonic dystrophy? Autosomal dominant. What is the chromosome affected? 19. Very, very good. Okay, fine. Any other triplet repeat? Very good. CAG, Huntington. GAA, Friedreich's ataxia. Okay. So in Fragile X, you have a characteristic feature called as Sherman's paradox or anticipation phenomenon. So as the generation increases, the possibility of Fragile X increases. So that phenomenon is called as anticipation phenomenon or Sherman's paradox. Okay. One more MCQ, tell me Rett syndrome. What is the newly approved drug in Rett syndrome? Newly approved drug in Rett syndrome? Yes, trofinetide is the newly approved drug in Rett syndrome. Okay, fine. Okay, so vitamin C, you all know hydroxylation of lysine and proline. So scurvy, bleeding gums, scorbutic rosary. Here you have tender and angulated rosary, anorexia, delayed wound healing, subperiosteal hematoma. But vitamin C also has radiological features. In the class we have discussed. So Pelkin spur, pencil thin, cortex, and then Trommelfeld zone, Wimberger's ring, all this. If you see the X-ray, you should be able to understand. Okay, another zinc deficiency. There is an autosomal recessive condition called as acrodermatitis enteropathica, which is due to a gene defect called as ZIP4 gene. What are the features you will see? Periorificial rashes. Around the orifices, you will have rashes. Diarrhea, alopecia. So alopecia, I already told you in biotin. Here also think of alopecia. One more important thing, hypogonadism. So I think there was a question in INA set. Hypogonadism seen in which deficiency? It is seen in zinc deficiency. Okay. So this is zinc deficiency, acrodermatitis enteropathica. They can give you image and also they can ask you. Okay. Fine. One more important topic every year which is being repeated is diarrhea. I thought we will cover diarrhea also. Okay. So diarrhea. So first important thing, most common cause of diarrhea in children is what is it? Most common cause of diarrhea in children. Viral, which is rota. Okay, rotavirus is most common cause of diarrhea in children. So first thing is you have to know how to classify diarrhea based on dehydration. No dehydration, some dehydration, severe dehydration. Okay, two questions came from INSET in the same diarrhea. Okay, so I've been stressing you so many times. No dehydration, everything will be normal. Some dehydration, two things you're going to see. What are they? Mental status and thirst. So some dehydration, how will be the mental status? Mental status? Yes, irritable. And thirst will be increased. Severe dehydration, the child will be lethargic or comatose. And thirst will be absent. Okay, refuses to feed. Refuses to feed. Fine? Okay. So, plan A, no dehydration. Plan B, some dehydration. Plan C, severe dehydration. Plan A, home available fluids. Yes. Plan B, ORS. How much ORS? 75 ml per kg over 4 hours. Okay. Yes. Plan C, IV fluid. What IV fluid is used? RL is used in dehydration. If there is shock, use NS and then go for RL. So total 100 ml per kg you're going to do. You will divide it into 30 ml and 70 ml. Depending upon the age, you will change. Okay. Less than 1 year, more than 1 year, Less than 1 year, 30 ml is going to be given in 1 hour. 70 ml is going to be given in 5 hours. Total duration 6 hours. More than 1 year, yes, half the duration. 30 minutes, 2.5 hours. Total duration 3 hours. Okay, fine. ORS. What is the total milliosmolarity you see in ORS? 245 milliosmoles. Okay, what are the compositions? Glucose, sodium, chloride, potassium, citrate. Glucose 75, sodium 75, same. Chloride 65, potassium 20, citrate 10, 245 milliosmoles is going to be. What is resomol? Yes, what is resomol? Yes, very good. Resomol is rehydration solution for malnourished children. Okay, it is for malnourished children. So how can you do resomol with ORS? Instead of mixing ORS with 1 liter, you mix the same ORS with 2 liters, and then you have 50 gram of sucrose and 40 milliequivalents of potassium to it. You will get resomol, which is used in SAM. Okay, very good. Okay, fine. So most of the topics, I think we have discussed almost more than 20 topics. Okay. So here, other than this, what is the must topic which you should know before going to the exam? I'll just tell you. One is NRP, Neonatal Resuscitation Program. Definitely you should study before going to exam. Okay. Next is the developmental milestones. Sometimes they ask, sometimes they don't ask. So, okay. But if at all they ask, if it comes as a match the following question or multiple option question, then you can find it difficult. So development milestones, you revise before going. NRP, you revise before going. And one more disease is Wilson disease. Okay. Wilson disease, inborn error of metabolism. Okay. Which I have not covered today. Maybe in the study with me session, we can cover about inborn errors of metabolism also. Okay. So these are all some of the important things you go to the exam. You revise and go to the exam. So Wilson disease alone, we will do it now, and I'll take up any doubts if you have. So Wilson, what is the mode of inheritance? Yes, ATP, 7B, chromosome 13, mode of inheritance. Autosomal, recessive. Yes, two important systems that is affected is going to be your liver and the CNS. So liver, you can have anything between hepatomegaly to cirrhosis. CNS will present with neuropsychiatry behavioral disturbances. Okay. Okay. KF ring. Where is the deposit seen in KF ring? Which layer? Yes, which layer? Yes, decimate. The KF ring is seen in decimate membrane. Okay, now tell me. So KF ring commonly seen in liver or CNS. Which manifestation is most commonly associated with KF ring? CNS. Neuro-Wilson is most commonly associated with KF ring. Okay, fine. What is the definitive investigation you will do? Investigation of choice. All these are investigations, but choice, gold standard. What is it? Gold standard? Hepatic copper content. Okay, hepatic copper content. Hepatic copper, if it is more than 250 microgram per gram weight of liver, you call it as positive. Other investigation, as you told, urine copper excretion will be increased. Then serum ceruloplasmin will be. What happens to serum? Yes, very good. Low. Okay, these are the other features. Okay, treatment. Chelators, what are the drugs? Yes, D-penicillamine can be used. Trientine is another drug that can be used. For maintenance therapy, you can use zinc. And for CNS manifestation, Neuro-Wilson, what is the drug? Ammonium tetrathiomolybdate. Okay, ammonium tetrathiomolybdate. This is the drug which can use in CNS manifestation. One more IEL point I want to add. So, you have an hematological manifestation of Wilson. What is that? Hematological. What anemia? What hemolytic anemia? Yes, Coombs negative hemolytic anemia. Okay, Coombs negative hemolytic anemia. Coombs negative hemolytic anemia. Okay, fine. Okay, any doubts or any other extra doubts you have? So almost 25 to 30 important topics we have covered. Definitely you will get at least 4 to 5 questions for sure from these topics. Okay. Okay, so I'll take up the questions. So any doubts you can ask me. Okay, Dr. Nandini, double malleoli sign is nothing but see, because of the widening of wrist and the epiphysis becomes wide, no. So in the ankle, you will have another bony prominence because of the widening. So it will look like two malleoli are seen. Okay, that is called as double malleoli sign. Is Dr. Kawasaki any type of rashes you can see? You can see like maculopapular rash, can you see? But vesicular rash is very rare. Okay, usually you will have kind of maculopapular rashes and all. Okay, fragile X is X-linked dominant. X-linked dominant. Fluid in pediatrics is the for maintenance in pediatrics you will use DNS. Okay, so DNS is what there is 5% dextrose with normal saline is what we use in for maintenance therapy. If there is a case of diarrhea, then you will go with ringalactin. Okay. If you're going to go for shock management, then you'll go to normal saline. Dengue shock also normal saline. Okay. These are the fluids. If it's a SAM child with shock, then the protocol changes. There you will go with RL with 5% dextrose of normal saline with 5% dextrose. Okay. These are the fluids we usually use in children. Doctor, as of now, pediatric textbook says most common cause of epiglottitis is H influenza B. Okay. Is Resomal. ORS, Resomal. RESOMAL. Okay. Resolvable hemolysis. It's not Resomal. Rehydration solution for malnourished children. Rehydration solution for malnourished children. Okay. Yeah, refractory rickets, so many times we have discussed in the class also. So this is available in OPICA also. In our workbook also, we have this flowchart. Okay, HPV schedule 9 years to 14 years, you give 2 doses. More than 15 years, you're going to give 3 doses. Okay. DKA fluid management. See, DKA, if a child presents with DKA, you're going to see whether there is dehydration or shock. If there is shock, you're going to give normal saline as a bolus immediately, 20 ml per kg as a bolus you give. If there is going to be no shock, only with moderate to severe dehydration, there you will give same 10 to 20 ml. The range is 10 to 20 ml of normal saline over a period of 30 minutes, not as bolus. That is the difference. After correcting dehydration, you will go with insulin. What insulin you will give? You will give insulin as an infusion, not as a bolus. Okay. Yes, doctor. Pneumonia classification less than 2 years, more than 2 years, there will be slight change. I don't want to confuse you, so I gave you an overall thing. So respiratory rate, very important, you have to see. In less than 2 months, actually, it's not less than 2 years, less than 2 months, more than 2 months, they have a slight change. So one important thing in less than 2 months, stridor in a calm child will come as a severe sign. Okay, that will be the difference. Is kernicterus, initial phases it will be exaggerated, but mostly absent moro. If exaggerated moro reflex is asked, go for hypoglycemia. Okay, hypoglycemia you will see exaggerated moro. Kernicterus later changes absent moro. Is for diarrhea with no dehydration, home available fluids will come first. Okay, and for ongoing losses you will give ORS. Okay. Yes, Dr. Giri, the duration of prophylaxis, HPV vaccine, it changes according to the brand which we use. Okay. For 3 doses, some brand is 016, but Servavac is 026. Okay. We give 026. 026. Okay. Dr. Hari Prasad, erythema toxicum. Okay. Erythema toxicum is a common condition which is seen in newborn. It is not of any worry. As the name says, it is a misnomer. Okay, it is not toxic and all. It is a common condition where you will see red erythematous rashes over the body of the child arising on day 2, day 3. After a week, it will subside. Okay, X-ray features of scurvy and rickets. Very simple. Rickets, if you see these serrated edges, cupping, praying, playing, rickets. If you see scurvy, it will be like a beautiful diagram. It will be like you're drawing with a very thin pencil. Okay, so that will be scurvy. Rickets, cupping, playing, praying will be seen. Scurvy, you will see as the sign I told you, Pelton spur, pencil thin cortex, Wimberger ring, okay, and you will see the Trummerfeld zone. Okay, Resomal, you mix the ORS in 2 liters, add glucose, that is sucrose, 50 gram of glucose you will add, 40 milli equivalents of potassium chloride you will add. Yes. Yeah, Gardasil, you have 2 types, quadrivalent vaccine, nonavalent. Quadrivalent is 6, 11, 16, 18. Nonavalent is it has extra 5. Total 9 strains will be there. They will not ask you the name of the strains and all. Okay, 6, 11, 16, 18 will be there. Extra strains will be there in Gardasil. Fluid management, if it's going to be a maintenance fluid, go for DNS. Okay, 5% exposed with normal saline. If it's going to be for shock, any shock, go for normal saline. Okay, dengue shock, any shock, go for normal saline. But the same shock in a case of severe acute malnutrition, SAM, you will go with RL. Okay, RL and 5% dextrose. Okay, next diarrhea, go with RL. Okay, these are the usual fluid you will use. DK also, you will use normal saline. Okay, dehydration management and shock correction is very important in DKA prior to starting insulin. Yes, any other doubts? Okay, so if you have any other doubts also, you can personally send me a message. So tomorrow when you're doing the study with me session, I will clarify those doubts also. Okay. Anything else other than these topics which we have discussed also, you can show. Okay, so if there are, I think I answered most of your queries. Yes. Okay, guys, thank you. Yes, periventricular, Dr. Preeti, periventricular calcification, periventricular CMV, diffuse toxoplasmosis. Okay. Fine. Okay. So if there are no other, causes of spastic quadriplegia, the cerebral palsy, you will have spastic quadriplegia. So, just a minute. So spastic quadriplegia, cerebral palsy. So think of cerebral palsy. Whenever there is a problem with the parasagittal areas, the watershed injury, the cerebral cortex is involved. And if you see something called a cystic encephalomalacia, okay, all these are features of spastic quadriplegia. Quadriplegia, all 4 limbs are affected. Spastic diplegia, where lower limbs are more affected than the upper limbs. Think of preterm baby with periventricular leukomalacia. Okay, so if there is a problem with the cerebellum, they will present with ataxic CP. Okay, if they present with chorioarthroid type of CP, there is a problem with the extrapyramidal system. Okay, exaggerated Moro hypoglycemia. Okay, absent Moro means Moro is not there. So it could be a very extreme preterm baby or a baby with HIE, hypoxic ischemic encephalopathy. The baby is depressed, so the Moro is absent. And in later stages of kernicterus, the Moro can be absent. Kernicterus is actually a chronic complication. Okay, kernicterus is not in the immediate newborn. It is a chronic complication. If you want to say in immediate newborn, say it as ABE, acute bilirubin encephalopathy. Okay. Next, unilateral Moro. Only one side there is Moro. Think of Erb's palsy, anything to do with hemiplegia, one side hemiplegia or clavicle fracture, shoulder dislocation. Okay. Incomplete Moro. Only 1 or 2 components are there, not complete. Then you think of preterm. Okay. Fine. Okay, guys. So I think most of the doubts are clear. So any more doubts, you just note it down. Tomorrow we will clarify all your doubts. Okay. Spastic diplegia, preterm baby, periventricular leukomalacia. Look for these 2 sentences. Periventricular leukomalacia, preterm. Diplegia means lower limbs are more involved than the upper limbs. Okay. Thank you. So keep studying. All the very best for your NEET. So anyhow, we'll be meeting again in study with me session. So any other doubts, you just ping me. Bye. Take care. Bye.